Hey everyone, let's dive into this explainer on the new Catalan Society of Gastroenterology guidelines.
Stop the meds or risk the bleed. It's the ultimate clinical dilemma, right? Clot versus hemorrhage.
So today, we're exploring how we carefully balance these risks during elective endoscopic procedures.
First up, procedure types. We've got low-risk diagnostic scopes versus high-risk interventions like ESD.
Basically, anything with a 1% or greater chance of major bleeding is considered high risk.
On the flip side, look out for severe thrombotic risks like recent coronary stents or AFib.
Okay, let's break down drug management, starting right off with antiplatelets like aspirin.
The golden rule for aspirin, usually keep it going, unless it's an endoscopic papillectomy. Stop 5 days prior.
For P2Y12 inhibitors like clopidogrel, stop them 5 days before high-risk scopes, then restart a day or two after.
But here's a cool exception. You can actually keep them going for small, cold snare polypectomies under 10 millimeters.
This balancing act gets way more precise when we shift over to managing anticoagulants.
Taking vitamin K antagonists, stop warfarin 5 days prior and acinocumarol 3 days prior to high-risk scopes.
And if they're high thrombotic risk, they're definitely going to need bridging therapy with heparin during that pause.
For DOACs, it's pretty simple. Don't stop for low-risk scopes, but definitely pause 2 days before high-risk ones.
Resuming DOACs might be delayed up to 7 days for complex procedures like ESD, depending on bleeding risk.
Quick tip, diagnostic enteroscopy often turns therapeutic, so just treat it as high bleeding risk from the get-go.
Ultimately, all these crucial decisions come together in the official algorithm flowchart. It's like a giant puzzle solved.
This matrix is basically your ultimate cheat sheet, mapping out every drug class against bleeding and thrombotic risks. So, key takeaways: multidisciplinary coordination and clear patient communication are literally lifesavers for procedural safety.
With these new guidelines in hand, how will you balance the scales for your very next endoscopy patient?